You're listening to the Beyond Measurements and Image podcast, where we build healthier lifestyles, elevate your well-being, and transform lives. Welcome to BMI.
I'm your host, Dr. Drew Crawford. I'm a board-certified gastroenterologist and obesity medicine specialist. Thank you for joining me today on Beyond Measurements and Image. Today we're going to talk a little bit about prediabetes. So what is prediabetes? Why does it matter? What does it turn into? And more importantly, what can we do to try to stave it off if it's upon us already? So let's first discuss what it means to be diabetic. So we all generally know what diabetes is, right? There's type 1 diabetes, which is where you have basically complete obliteration of the beta cells of the pancreas. So the beta cells of the pancreas make insulin. So oftentimes you have just complete obliteration of these, probably secondary to a virus or something happens. Oftentimes this occurs in childhood. These people are completely insulin dependent. They have to have insulin. They make no insulin in and of themselves. The second type of diabetes is just that. It's called type 2 diabetes, and it's more common in adults. In fact, it used to be called adult onset diabetes. For the most part, it's not necessarily insulin requiring, but some people who have type 2 diabetes are on insulin. They don't have complete obliteration of their beta cells, although the beta cells don't make enough insulin. And then what happens is they become insulin resistant, which is a whole different process. And so with this, they have elevated blood sugars and then all of the consequences. Why do elevated blood sugars matter and what does it mean? Well, what happens is when you have elevated blood sugars over time, it really wreaks havoc on the small vessels and sometimes the bigger vessels within our body. So oftentimes long-term diabetics have problems with vision. Sometimes they go blind because of the tiny little blood vessels in the back of their eyes. And then oftentimes these smaller blood vessels in the lower extremity end up getting damaged from the chronic elevated blood sugars. And so a lot of times people who are long-term diabetics end up losing part of their foot or part of their leg or maybe both legs. And so also the blood vessels that go to the kidneys end up being affected. And that can cause problems with high blood pressure. And a lot of times diabetics end up on dialysis, which is basically a filtering system that the kidney normally does. But if your kidneys no longer work, you go in and you have dialysis 3 or 4 times a week. And what they do is they hook you up and they pull all the blood out of your system, run it through this dialysis machine and kind of filter the blood and then put it back into your system. Those are sort of the consequences. There's also an increased incidence of heart disease and all sorts of problems that go with diabetes, but that's a different conversation. So what is the diagnosis of diabetes? Well, the diagnosis of diabetes is made with lab tests, particularly elevating your blood sugar. So there's 3 tests. One is just to do a fasting blood glucose level. So a fasting blood glucose level is simply where you don't eat or drink anything for 8 to 12 hours, and then you go into a lab and they draw your blood. And if your fasting blood glucose level is greater than 200, that's diagnostic of diabetes. Now, the other thing they can do is they can check what's called the hemoglobin A1C. So the hemoglobin A1C tells you what your blood sugar is sort of over the last 90 days. Now, it's not precise, but the average life of a red blood cell is about 90 days. And so the percentage of hemoglobin molecules that are coated in sugar or glycolated as a percentage is your hemoglobin A1C. And so a hemoglobin A1C greater than 6.5 is diagnostic of diabetes. Then there's a third test called the oral glucose tolerance test. And that's a test where you go into the lab and you're fasting again. You have not had anything to eat or drink for the past 12 hours. And then in the lab, they give you a very precisely measured solution with 75 grams of glucose in it. And so they know that, and then they know how the body should respond. So they have you drink that solution with 75 grams of glucose. Then they check your blood at 1 hour, at 2 hours, and at 3 hours. And if the blood glucose is greater than 200 at 2 hours, that's diagnostic of diabetes. Now, there's also some gestational diabetes, which is the diabetes associated with pregnancy. With that, the tests are a little bit different. But basically, there's 2 tests. There's just the standard test, which is when they give you 50 grams of that solution. And then there's a 3-hour test where they give you 300 grams. So that's kind of a different story altogether. But those are the ways you diagnose diabetes based on lab. a fasting blood sugar greater than 126 on 2 occasions. It has to be documented on 2 occasions. Second, a hemoglobin A1C greater than 6.5. And third, a oral glucose test where your 2-hour glucose measurement is greater than 200. So that's the diagnosis of diabetes. So then what is prediabetes? Well, of course, you don't go from being normoglycemic or just having normal blood sugars and being able to regulate your insulin and blood sugar and manage all that completely normally one day, and then the wheels fall off the cart the next day and you're diabetic. There's a spectrum that you go through, and that spectrum is what we call prediabetes. So those same tests that we talked about for the diagnosis of diabetes are the tests that we use to diagnose prediabetes. Now, the parameters are a little bit different. Of course, the tests are the same. The fasting blood sugar, you go in fasting for 12 hours. They draw your blood. If your blood is 100 to 125, that's diagnostic of prediabetes. If your hemoglobin A1C, remember the one where we look at the 90-day, sort of the average blood sugar over the previous 90 days, if it ranges from 5.7 to 6.4, that's diagnostic of prediabetes. And on the oral glucose tolerance test, where they gave you the solution that you drank and then checked your blood at 1, 2, and 3 hours, if your blood sugar at the 2-hour mark is between 140 and 199, that's diagnostic of prediabetes. So why does prediabetes matter? Well, prediabetes, if you can identify when you're prediabetic, you can start to make moves to prevent you from becoming diabetic. Prediabetes is simply that. It's just blood sugars that are higher than normal, but they don't actually meet the criteria for diabetes. There's almost 100 million adults in the U.S. that have prediabetes. And the problem is most of these people are asymptomatic. There's really no particular symptoms that are consistent with prediabetes. Now, sometimes if you have diabetes or you're just running high blood sugars, oftentimes you might have excessive thirst or you might urinate a lot. Sometimes you can get these kind of dark patches around the back of your neck or your armpits called acanthosis nigricans. But in terms of symptoms or physical signs that you can see, it's very difficult. There's really not much. And again, it's such a subtle process because you don't develop symptoms overnight necessarily, right? It's just this gradual spectrum. So if you are drinking more water, it's probably not that you're drinking way more water today than you did yesterday. It's just this gradual process where you're drinking more and you're urinating more. And that's just because you have elevated blood sugars. Now, there's a whole host of reasons that can cause that. That's not the only one. But sometimes these things just sort of sneak up on us, and they're just these sort of little lifestyle changes that we just adapt to and we don't think much of. So having your physician check your blood count and specifically running these tests is really valuable. So if you can get a diagnosis of prediabetes before it develops into just overt diabetes, it's just easier to start to reverse the process. Now, even type 2 diabetes is oftentimes reversible, but prediabetes is just caught a little bit earlier and just gives you a little bit better handle on things and a little bit of a lead time in terms of reversing it. So who's at risk for developing prediabetes? Well, anybody over the age of 45. If you're overweight or obese, that increases your risk. If you have a family history of type 2 diabetes in a sibling, a child, or a parent. And then, of course, if you have a sedentary lifestyle. Oftentimes, a sedentary lifestyle leads to the excessive weight. And unfortunately, as we age and get greater than 45, we tend to become more sedentary. An even better predictor for prediabetes or diabetes is waist circumference. In men, a waist circumference greater than 40 inches, and in women, a waist circumference greater than 35 inches is predictive of prediabetes or diabetes. And that's significant because overweight and obesity can lead to it, but where that weight is distributed matters, right? Remember, central obesity, we've talked about that. Central obesity carried around your waist is more visceral fat, and that just increases more metabolic problems, including prediabetes and diabetes. Additional risk factors. Well, in females, if you've had gestational diabetes with pregnancies or if you've delivered a baby greater than 9 pounds, is an additional risk factor. Also, certain races, Blacks, Hispanic, Latino, Asian, American Indians, and Pacific Islanders have an increased risk of prediabetes and type 2 diabetes. Why does that matter? Well, it matters because, like I said, about 100 million U.S. adults today have prediabetes. And we know that if nothing is done to intervene and to try to reverse this, about 5 to 10% per year go on to become a type 2 diabetic. So that means in 3 years, up to 30% of these people with prediabetes have an actual diagnosis of diabetes. And as that continues, if you don't do something to reverse it, then what happens is your risk just goes up increasingly. So what can we do to reverse prediabetes and to try to avoid a diagnosis of diabetes? The first thing, and probably the most important thing, is to make dietary modifications. We eat a diet in this country that's so processed and ultra processed, high in sugar and carbohydrate. So you really need to concentrate your diet into a high protein diet and to minimize the carbohydrates. And with that, if you can lose about 5 to 7% of your body weight, that really has shown significant improvement in diminishing the risk of going from prediabetes to diabetes. And then, of course, avoiding a sedentary lifestyle. The current recommendations are 150 to 300 minutes per week of moderate intensity exercise or 75 to 150 minutes of vigorous exercise per week. At 150 to 300, that's about 30 minutes a day, 5 days a week. And remember, in the last episode of the podcast, we discussed the 5 different modalities of exercise. And the one that was most effective in all parameters, including glucose management, was the combined training with the combination of continued endurance training, which was, walking, running, biking for approximately 30 to 60 minutes 3 times a week, as well as resistance training for about 30 to 60 minutes 2 to 3 times a week. But they need to be done in the same setting. So I'd encourage you to go back and listen to that. But it's not like you do cardiovascular one day and then turn around and do resistance training the next, right? That is an option. But when they looked at the 5 different endpoints, one of which was glucose management, the combined modality of training where you add a cardiovascular component or an aerobic component such as biking, swimming, running, let's say like on a treadmill, and then leaving the treadmill part of the gym and going and doing some resistance training. Doing that 2 to 3 times a week was the most effective way to do it. So losing weight, increasing your protein, decreasing your sugar intake and your carbohydrate intake, and increasing your exercise. Those are the things that you can do to limit your risk factors for developing diabetes. One last note, the continuous glucose monitors. They are the devices that we've talked about before that you can put on, usually on the back of your arm, and they measure your glucose just continuously, hence the name continuous glucose monitor. It transmits that data to your phone. And for diabetics, these are really life-altering, but they're good if you're not diabetic, particularly if you have risk factors. Remember, we talked about them, age 45, overweight or obese, family history of diabetes, or a sedentary lifestyle, right? If you have those, it might be worth buying one of those and putting it on and just watching, right? Don't do anything different to begin with. Don't change your diet and try to game the system and get the numbers you want, right? Put that thing on for a week or 2 or, a couple months, really, and just get the data. Eat what you normally would eat. Do the things that you normally do. If normally you just go sit on a couch all day, do that, right? And just eat what you'd normally eat. And then you can see what your blood glucose is doing. And it's fascinating because you'll see that if you eat and go walk, it really attenuates those spikes, right? When we eat, we take in all that food, protein, fat, carbohydrates, and our blood sugar goes up. But what we know is if you go walk right after your meal, that blood sugar doesn't go up quite as high and it kind of keeps it down. And these continuous glucose monitors are fantastic in that you get to see that in real time. Now, a couple of drawbacks to the continuous glucose monitors. One, they don't go into a blood vessel, right? So they're not checking blood sugar from like a vein or an artery like you would if you went into the lab. It's more just like interstitial fluid. So there's a lag from the time you eat and then what your blood sugar is actually doing in your veins and arteries versus what it's doing on the continuous glucose monitor. There's a delay of about probably 20 minutes, I'm guessing. But it gives you a good idea. And then the other limitation, and the reason I bring it up, is you can't rely on those to diagnose prediabetes or diabetes. They're just not quite reliable enough yet. I say that. Maybe they are reliable enough, but they haven't been approved for the diagnosis of that. So if you do that, if you have any of the risk factors, you have any of these symptoms, which like I said, is really a relatively asymptomatic process, and you're just concerned, either talk with your physician and get the testing done, or if you want to just kind of do it on your own, do the continuous glucose monitor and see what it shows. I think that'd be a great way to see it. I really like the idea of taking control of your health and doing things on your own. So the continuous glucose monitor does a great job of that. And then the other thing that we've talked about in the past is getting on something like MyFitnessPal or one of these apps where you can document what you're eating every day. Because I think if you realize what you're eating, you'd be surprised at A, how many calories you're taking in, and B, what the macros are, like what percentage of your calories are carbohydrates and what percentage are fat and what percentage are protein. And then it breaks it down into sugar and all these different minerals, vitamins, this, that, and the other. But if you just document it, right, you can't really make changes until you know where the problems are. And so documenting that and then maybe a continuous glucose monitor really gives you a lot of useful input to be able to sort of sort out what's going on and then to be able to make changes. So hopefully you find this useful today. I just wanted to discuss prediabetes and diabetes. We talk a lot about that. And in overweight and obesity, that is a big risk factor that we have. A future episode will be, how does obesity lead to diabetes? And that's a fascinating process in and of itself. But today, let's just focus on, are we pre-diabetic? If we are, what can we do to modify it so we don't become diabetic? If we are diabetic, what can we do to manage that? And of course, we've got all the different medications that we've talked about before, but avoiding insulin would be fantastic, right? The GLP-1s are really good for type 2 diabetes. And interestingly, there's no role for GLP-1s in type 1 diabetics. Remember, in type 1 diabetics, they don't make any insulin, so they have to have insulin to survive. So anyhow, hope you found this useful. If you have any questions or concerns, feel free to hit me up. That's all I have for today. Thanks for joining. I'm your host, Dr. Drew Crawford. Join me next week as we go beyond measurements and image to build healthier lifestyles and elevate your well-being on the BMI Podcast. See you then.